Welcome to the latest podcast from the Plastic Surgery Journal Club. Each month we review and appraise a journal article, typically from PRS, and summarize it for you in this short podcast. The full journal can be obtained from the PRS website.
Okay, welcome to the July 27th, 2016 Plastic and Reconstructive Surgery Journal Club, coming to you from Sydney, Australia. My name is Damien Marici. I'm talking with Dr. Harith Alani, who is a plastic surgery registrar at the Children's Hospital of Westmead. Harith, the next paper we looked at was SPY imaging use in post-mastectomy breast reconstruction patients, preventative or overly conservative. This is a paper also from the July 2016 PRS from Mattison et al. In Loma Linda, California. So what was this paper about?
It's a prospective diagnostic study in which the perfusion and the viability of 55 post-mastectomy skin flaps were assessed intraoperatively. So they assessed the perfusion by two ways. The authors compared the surgeon's assessment based on clinical judgment with that of the SPY elite imaging using indocyanine green injection. All patients have skin-sparing or nipple-sparing mastectomies, and they all ended with a breast reconstruction by tissue expander or implant. And when they compared the two ways of skin perfusion and assessment, they found that the surface area of resection was significantly less, according to the surgeon judgment, than the area of diminished perfusion indicated by the SPY analysis. They also found that nipple perfusion was variable and found to be diminished overall in the SPY imaging analysis, regardless of tissue surviving outcome. They concluded that the indocyanine green angiography can result in more aggressive resection than the area deemed viable by the operating surgeon. And its use does not play a useful role in low-risk cases where the operating surgeon identifies no areas of concern.
Look, I thought this was an interesting paper. At the end of the day, what we look at, or what we really need, is a tool which is going to let us know that whether the skin is going to survive or not. Based on this study, the SPY does not seem to be accurate enough in order for us to confidently resect skin just based on the SPY imaging alone. There was a commentary on this paper which was done by Loskin. We basically make the whole point that you need to put it in a clinical context. But if you look at the skin and you think it looks okay, or you think it doesn't look okay, and then you bring the SPY in, if the SPY, you know that if the SPY says it's okay, it's definitely going to be okay. But that really doesn't help us, because we want to know the skin that's not going to be okay. And I guess that's one of the issues. I don't know whether the company that manufactures this not insignificantly expensive machine are able to tweak the algorithms so that the accuracy and the predictive value can be improved or not. I'm not sure whether that can be done. But I think that until it's improved based on this study, I don't think it's going to be making you reach for the scalpel at times when you otherwise would have been happy just to put the scalpel down and start closing the wound.
Yeah, I think it's, in addition of, although it's introducing a new method of assessing the skin for assessment of the perfusion, it's an imaging technique with high false positive rate.
Yes.
There's an additional cost. There is no clear indication, actually. And I think it would be better if we compare the SPY image result with the actual rate of post-operative necrosis. At the end, I think there is nothing better than the eyes of an experienced surgeon assessing the perfusion of flaps in reconstructive surgery.
Well said, like an experienced surgeon. Dr. Harith Alani, thank you very much.
Thank you.
Thank you for listening. For more of our podcasts, head to soundcloud.com or subscribe to us on iTunes and search Plastic Surgery Journals. Remember to like us on Facebook and follow us on Twitter. Thanks also to the PRS Journal team for their ongoing support.